2024. We do have a quorum. Becky, if you would, please call the roll.
Senator Rocky Adams, Senator Chambers Armstrong, Senator Berg, Senator Carroll, here. Senator Elkins, here. Senator Funky Fromeyer, Senator Nemes, present. Senator Tishner, Senator Wise, present. Vice Chair Douglas,
present.
Chairman Meredith.
Present. Appreciate everyone being in attendance this morning. This train leaves the station on time, and we arrive on time, so we'll keep this within our allotted time frame. Slight deviation in the agenda. We're going to go with discussion of Senate concurrent resolution 42, and I ask Senator Douglas if he would to proceed to the table. Senator, I know you know the routine, but if you would, please identify yourself for the record and feel free to proceed.
Thank you, Mr. Chairman. I'm Senator Dr. Donald Douglas, District 22 State Senator.
Please proceed.
Thank you, Mr. Chairman. Good morning, Mr. Chairman and members of this esteemed committee. Senate Concurrent Resolution 42 is a document informing the Senate that the Legislative Research Commission has been directed to reestablish the Certificate of Need Task Force. A Certificate of Need is a government-mandated permission slip that is required before a firm can enter certain industries. In this case, we're talking about the industry of healthcare. As all on the committee are aware, there was a newly formed Certificate of Need Task Force assembled in the past interim to discuss and review Kentucky Certificate of Need program, including the state health plan, review the need for maintaining or modifying the Certificate of Need for 32 areas of healthcare service that are currently covered under our Certificate of Need, and to submit these findings and recommendations to the Legislative Research Commission for placement in the Committee of Jurisdiction. Informational input was sought and was allowed, taken from the public, as well as private contributors from the Commonwealth and even beyond the Commonwealth. People and institutions alike shared their concerns, their facts, and their ideas regarding this topic. When all was said and done, we felt that everything fell into three main categories, Mr. Chairman. Those who suggested and concluded that Certificate of Need is a concept that may or may not have served its intended purpose and is no longer needed to shape or protect our healthcare industry. They felt that Certificate of Need should therefore be eliminated and let the free market system govern the outcomes in healthcare. Another group were those who concluded that Certificate of Need was still needed to provide guardrails and protections for certain institutions and practice situations. These areas of healthcare are often seen as more challenging and see more challenged social economic groups, which may present in greater numbers with more complicated needs, which can lead to disproportionate reimbursement per service cost, leading to failure of that institution or of that particular practice. The third category seemed to be one that some people in the previous two categories could at least have some agreement on. And that is, Certificate of Need is much more complicated with many more moving parts than they had previously thought. And that perhaps these individual areas needed to be evaluated separately, and recommendations made based upon the importance and the impact that those individual services will have on our entire healthcare system. So let's kind of review what we felt we learned on the committee. As of July 23, there are 32 areas of healthcare that are affected or covered by Certificate of Need here in the Commonwealth of Kentucky. We also learned that our healthcare system, not only in the United States, but here in the Commonwealth of Kentucky, is not, and I repeat, is not a free market system. It's more of a hybrid system that is constantly changing and is quite different from many of the systems in surrounding states. There is this belief that certificate of need has been eliminated in many, many, many states. And with respect to that particular name, that is true. But these systems still, these type systems still exist in those states. They are just simply named something different. We also learned that different services and different technologies covered under Certificate of Need are impacted differently by the Certificate of Need process. And therefore, blanket changes are really likely to produce chaos. With that being said, Mr. Chairman and members of this great committee, we felt that wholesale changes in Certificate of Need could and likely would fundamentally change how we provide health care here in the Commonwealth of Kentucky. And if not done in a strategic and a well thought out way, it could exacerbate the problems in a healthcare system that is already struggling to recruit and retain competent healthcare professionals in all of these areas. Though some parts of Certificate of Need kind of went into effect in 1972, the General Assembly really did not enact laws regarding Certificate of Need until 1980. I think that's important. I think that time period tells us we don't have to rush. We do not need to rush, and we should not rush this. It would be short-sighted to make blanket changes without further study to allow more appropriate and more accurate predictions of future and fair outcomes in the healthcare space. I therefore ask this committee to accept this recommendation and to empower the Certificate of Need Task Force to be reconstituted in the interim in 2024 for further discussion and for final recommendations regarding the individual areas of service covered under the Certificate of Need. I'd like to thank the committee for listening to me this morning, and I will open up for any questions if there are any.
Thank you, Senator Douglas. I'm sure there'll be some questions, and I appreciate you presenting this today. Task Force, the shelf life of it is a year. We go through the interim, and we make recommendations, and we move on. But I think you've outlined very well why we're looking at the continuation, recommending continuation of this task force. It was a learning experience for, I think, everyone who participated, and I appreciate your desire to go in a very stepwise fashion to try to address the true healthcare needs of Kentucky. We know we've got some work to do, so I commend you for that and commend you for your leadership during the task force. Senator Funky Fromeyer, you have a question, comment?
Senator Douglas, thank you for bringing this forward again. And I had such a good opportunity during the interim, both in our Health Services Committee, but also kind of as a guest of the Certificate of Need Task Force. I wasn't on the task force, but was able to listen in. And I want to commend you on your leadership of challenging many presenters to use the words, not the acronyms. There are so many complexities to our health delivery system, and I recognize better than ever some of those complexities and appreciate spending time with you and talking through some of those. What I am trying to better understand, because I've heard the state health plan referenced a number of times, and as a financial advisor, health isn't my specialty, but the cabinet, I am learning, is incredibly robust with experts and leaders. What is the cabinet reflecting our pros and cons, or is that a place for our cabinet for Health and Family Services to really recognize or provide to us legislators a little bit more on the pros and the cons within perhaps even area by area, all 32 areas that you shared with us today.
Well, I think that having the cabinet weigh in, or at least give us some ideas, would be helpful. One of the things I struggle with often is that we take recommendations from agencies and organizations who are not boots on the ground. And I've talked about this, especially in our academic space, where we often have our tertiary care centers or our academic institutions making recommendations based on, quote, research that they've done. And I've been challenging them to get out and talk to the boots on the ground people, and especially in the healthcare area, to get out and speak with the physicians to see why physicians are leaving the healthcare space, to see why physicians want to stay, to talk to our nurses. I think it's wonderful to talk to medical students. I think it's wonderful to talk to residents. But the truth is, they don't have a clue what goes on in the healthcare space other than what they're being told when they're training. And I would say I was there when I was training. Unfortunately, being the old guy, I've been in the healthcare space now for almost 40 years. And I realize how little I still know. So I get a little concerned when I have bureaucrats who are running areas. The recommendations are wonderful, but in their input, it's wonderful. But I'm just an old country boy who says, if I want to know how to be a really good farmer, I'm going to ask the farmer. And I think we need to spend more time asking those people who are the boots on the ground.
And I so appreciate that. I wanted to follow up to acknowledge that I also think perhaps we need to hear more from the patients. I don't know that we've taken enough time to really walk in the shoes of what our patients are experiencing, whether they're a Medicaid, Medicare, private pay, self-pay, that I think that also has a tremendous influence that perhaps we weren't taking into consideration during the last 8 to 10 months of our review and discussions of Certificate of Need. I believe we're struggling with innovation, and I often hear that from my constituents, but those are the payers we would expect. But if we're going to improve health outcomes, I think we also need to be speaking with our patients more.
Mr. Chairman, may I respond? Senator Perlmeyer, I couldn't agree with you more. However, as a provider in the healthcare system, I often discuss and talk about breadth and depth of knowledge. Individual patients look at the healthcare system from their view. They don't look at the healthcare system from their neighbor's view. They don't look at how it's going to affect their neighbor, or the person down the road, or the person in another city. Physicians and people in the healthcare system look at how not only what they do for patients is going to affect that particular patient, but how it will also affect their ability to interact with their family, with their friends, with their loved ones. So the picture that we look at in the healthcare system is not an isolated, and I don't want to use the word selfish in personal position, but I mean, I'm saying that patients see a little bit smaller picture. And we're talking about a healthcare system. We're not talking about a system that we would love to be able to have a system that serves every individual in their individual way. What we have is a healthcare system that serves every patient in a unique way that fits into a form that allows the healthcare system to serve as many people as possible in that unique way.
Any other questions, comments for Senator Douglas? Senator Tichenor.
Thank you for being here, and thank you for sharing this. I followed just a little bit during the interim, and it was really interesting discussion. Do you intend on expanding the task force, inviting new members to be a part if if it is extended for another year?
I don't think that I get to make that decision. That is someone else's decision. I will follow the decisions that those people who are designated to reconstitute the task force allow me to follow. One of the things I don't want to do is I don't want to reinvent the wheel. This is an education process for many, many people in this particular area. Again, I've been in healthcare for a long, long time, so I've dealt with this for a long, long time. There are those who previously, when they came to the task force, had not spent much time in this particular area. And the one thing I really enjoyed hearing was the learning process that they talked about. My concern, if I may share, Mr. Chairman, is continuing to bring more people into this space does not necessarily increase the depth of knowledge of the subject of the people who are on the task force. It may widen the number of people who participate, but those who've been on the task force have spent a lot of time, and I really want to thank those people who participated in the task force this past interim. They did an absolutely great job. They participated and they learned, not just while they were in committee, but away from the committee. And so I really, really appreciated the staff that we were able to work with. They were absolutely wonderful. And I'm concerned that we will have people on the task force, some who are very, very, very aware of more in-depth issues, and those who are now learning. And I'm just concerned with that differentiation there.
Thank you. Any other questions, comments? If not, Senator Douglas, I appreciate your presentation this morning. I think it was very important. People understand what we're trying to accomplish with these task force, and look forward to its work during the next interim. So,
thank you so very much,
thank
Mr.
you.
Chairman, and thank you all members of the committee.
I appreciate if you come forward and assume the chair so that I can present Senate Bill 24.
Good morning, everybody. I know we've already started this particular committee meeting, but I want to welcome everybody, and I want to start out by thanking the staff who helps us here in this committee. They do an absolutely wonderful job. We always thank them at the end of our sessions, but I want to step up front and thank them ahead of time. I also want to thank the people on this committee who take their time and who are very diligent about the work that they do. And I want to thank you all for the work and the sincerity that you have regarding taking care of your constituents and standing up for your constituents in your district. With that being said, Senator Meredith, would you? I actually want to say we have the esteemed Senator Meredith here, and we are very much looking forward to what he has to say today. So if you would, sir, please introduce yourself for the committee.
Thank you, Mr. Chair. I'm Steve Meredith. I'm State Senator for the 5th District, and I appreciate the opportunity to present Senate Bill 24 this morning for your consideration.
Okay. Senator Meredith,
Yes.
would you oh, never mind. Go ahead. I'll let you go.
Are you sure? I'm always at your beck and call.
I know you are, sir, and that's why I so much enjoy being on these committees with you.
This is, I look at Senator Wise and Senator Carroll when I say this. This is the 7th time I've presented this bill. 7th. And I've got to admit, I wasn't going to do this bill again this year. Kind of get beat into submission, but I love history, and I'm reminded of Robert the Bruce, the first King of Scotland. And many know that he was defeated by the English time and time and time again, and he was demoralized and ended up going to hide in a cave and I guess contemplate what his future was. And legend has it that he watched a spider try to weave a web and failed each and every time until the seventh time, and then it succeeded. And he thought, I need to do this one more time, which he did. And history will tell you that over overwhelming odds, he beat the English and let Scotland become a free nation. Of course, that's changed over the course of history. So, I'm not pretending to be Robert the Bruce, but I think this legislation, the current state of healthcare, certainly warrants the same kind of consideration. It's easy for me to sit by and just say, well, let's just let it happen. But, I was in healthcare for 40 years. I've been retired for 10. And certainly continue to follow this as chairman of this committee, but I've got a 50-year time frame for healthcare, half a century. And I'm telling you, over that 50-year period, a lot of challenges for healthcare providers. They come and go, different challenges, but I've never seen a time where it's more precarious for healthcare providers and more fragile than it is today. And that doesn't just affect providers, but it affects our patients, our constituents as well. Challenges as never has been before. Nationally, and I'm surprised this doesn't get more attention, we're approaching close to healthcare being 20% of our gross national product. We're spending close to $13,000 per capita on healthcare. That's double what other industrialized nations are spending. The next closest is Germany at $7,000. Now, if this ever exceeds 20% of our gross national product, I truly believe that it will cause our economy to collapse. We cannot continue to sustain this because it makes us non-competitive in an international marketplace. I mentioned Germany, $7,000. China spends $650 per capita. So how can we competitively have our products and services in the international market when we have this much we're spending on healthcare? And the reality is we don't need to be. There's enough money in the healthcare delivery system to take care of every one of the child in this country if we spend it the right way. But we don't have a tendency to do that. Kentucky specifically, this year our Medicaid budget alone will be between $15 and $17 billion. When I came in 2017, my first year, it was $10 billion. At that time, we were serving 1.4 million people. Now we're at 1.7 million people. And our health outcomes are not any better at all. And we're seeing healthcare deserts like we've never seen before, both rural and urban. We're seeing historic inflationary pressures on healthcare providers. And we're seeing shortages in every healthcare profession across the board. This is a crisis of biblical proportion that we're about to see. And it's even more pronounced in rural communities. And I'm very proud of the fact that we do have 1.7 million of our people on Medicaid. I mean, they have coverage, but that's not consistent with having access to health care because they don't. And I'll share one quick story with you. Most of you know my youngest son is a family medicine physician. And a couple of years ago, and he practices in my home community, or he did, and I ran across a friend in an event, social event, and they said, hey, I'm going to see your son. He's going to be my physician. This was in October. I said, great. When's your appointment? February. That's not an extreme. I mean, an extreme situation, but that's an everyday occurrence in healthcare anymore, particularly in rural Kentucky. 40% of our population is rural Kentucky. Only 17% of our primary care physicians are there. And every day that we don't address these inefficiencies of the system is every day that makes this situation even worse. And people are very mistaken that they think that, well, you can always drive 30 miles up the road to see another physician. If you live in rural Kentucky, you know what a burden that is for many people, particularly elderly and the poor, particularly gas prices the way they are today. So, how can we address this? And I think our discussion on certificate of need was kind of an attempt to do that all over the board. But I think one of the easiest areas to address is the administration of healthcare. Again, we're spending 30 cents of every dollar on the administration of healthcare in this nation. That's double what other industrialized nations are spending. For on a Medicaid program, we give the MCOs 10% off the top. Our Department of Medicaid, their expense percentage is about 6%. That doesn't even factor in the expense for the providers. And I would venture to say probably we're spending close to 40 cents of every dollar of our Medicaid dollar on the administration of health care. Now, what I have preached since I've been here is that we can address this and do it immediately. And I'm sure during this interim that you folks have heard from various groups of healthcare providers, and what they're asking for, higher reimbursement, more money for their employees, and the reality is we're not going to be able to meet everybody's needs. We're not. And historically, what we've done is kind of played whack-a-mole, and whoever yells the loudest kind of gets the increase, and then we come back 2 sessions later and we do the same thing over and over again, and that's not a good system, but it is the system, unfortunately. So, where's it going to end? One area I think we can immediately address is the administration of health care for our Medicaid program. We have 6 managed care organizations, and I'd ask you, why? What's magical about that number? Who decided that 6 is the number that we need to have? Why not 8? Why not 10? Why not 2? Federal government only requires 2. We have 6. Now, the answer I get is because of the risk involved with insuring this particular population. And we have a tendency to forget history conveniently sometimes, but other times we use it for our own benefit. And one of the arguments I get for reducing the number of MCOs, you remember when this program started, managed care started in 2012, we had 6 MCOs, and one failed almost immediately and created chaos throughout the system, and it was a true disaster. But that's what happens when you don't plan strategically to implement a product or a service. And I think we continue to live with that ghost even today. Remember, insurance is a risk business. And Senator Frank Farrell, you probably know that more than anybody. California, which is 10 times our population, has 26 MCOs. Per capita, it's 1.6 million people per MCO. In Kentucky, with our 6, we're seeing about 750,000 per capita. So what that says is that risk pool is not nearly as dramatic as it is for a state like California. Another reason I decided to pursue this bill once again is we heard testimony this summer from our colleagues in Tennessee. Tennessee, 1.7 million Medicaid recipients, just like Kentucky. Now, the difference, and I got to note this, is Tennessee's population is double what ours is. And this is about 12% of their population, where ours is hitting close to 40%. But nevertheless, 1.7 million population in Tennessee. How many MCOs do they have? 3. Again, federal government requires 2. Then we had the report on Senate Bill 50, the single source PBM bill, which Senator Wise passed a couple of years ago, a great bill that reduced the number of PBMs that work directly with the MCOs from 6 to 1. And he and I, along with Senator Carroll, heard just damning testimony that the world's going to come to an end whenever we went to one PBM, that it was going to cost our state millions of dollars. And we knew, and we didn't have any real data to work from. We just had some gut feeling about this, that there's substantial savings there. And you folks know that we saved $285 million by going to a single source PBM. And when we had a report on this from the Department of Medicaid, we said, what was one PBM able to do that 6 could not? I said, well, part of it is efficiency. Certainly, because you're only dealing with 1 rather than 6. So not as only a burdensome administrative expense to healthcare providers, but to our own cabinet. Why do we do that? We don't need that. Senator Carroll and I really have a passion for the Michelle P. Waiver program, and we are begging and pleading everywhere we can to find more funding to reduce that wait list that we have. And here's an example. We can use the savings from this fund, and I think it would be substantial if we go to 3 MCOs. Now, Senator Elkins, because he's a businessman, you can imagine being in the business where 70 to 80% of your business you lose money on. And adding more customers who lose money doesn't help your financial position. But the administrative burden, it's so substantial. Each MCO requires their own contract, requires their own credentialing and re-credentialing, requires their own pre-authorization request. They have their own process for billing and claims. They have their own documentation requirements. You have 6 different sources of communication with their networks and their people. You have to interpret regulations from 6 different groups, and you have to go quality assurance programs for each and every one. Can you imagine as a businessman if every product you sold, you had to have 6 different rules and guidelines to sell that product, particularly when you are losing money on those particular people. Let me share some comments with you, and I think we have a tendency to look at this as mostly a hospital problem, hospital system problem. It's not by any means. We've got just hundreds of healthcare providers that can be considered not just healthcare providers, but small business people. And they have to carry this burden of 6 different set of rules for the same service. Here's some comments we've received from them. We've increased our administrative staff from 7 to 11 after implementation of managed care. Quadruple our administrative and billing staff since implementation of managed care. Received an average of 600 MCO audits per year from 2018 to 21. In 2022, we had 2100 MCO audits. Completing 4 different types of audits from 6 different MCOs. As soon as one complete, I'm being asked by another to provide medical records for another audit. It's a moving target. We never know what the rules are, and just when we learn the rules, the MCOs change them. We must respond to multiple audits from different MCOs at the same time. The administrative burden continues to grow and is multiplied with every MCO we must work with. Completed 1 audit for specific treatment services and received 100% the next week. Completed another audit for the same service with a different MCO and received 0. Now, in this particular provider, this was a small mental health provider, services, I think it's a 5-county area, rural area. When she had this audit, it said, you owe us $25,000. Of course, you can appeal it, which she did. A year later, there's no resolution to this. To a small business person, that closes the doors. And a small business person, she had, I think, 5 employees, and, you eliminate those jobs. You have to. This one says on December 6, 1921, received a request for an independent review to appeal on audit findings and recruitment of services provided in 2019. We received a letter from the Academy of Health and Family Services on July 22nd. Let us know that they were forwarding our request through the Island Peer Review Organization. As of today, a year later, we still do not have a resolution. Had to hire an attorney to help us. Imagine doing this for 6 different audit findings. It's exhausting. We just need consistency across the board and having to implement rules 6 different ways. Now, most people know I'm not a fan of the managed care organization model. I think there's a better way, but I'm not ready to fight that battle. Don't know there can even be one. But we can certainly simplify this for providers. We should. And there's a savings, again, not just providers, but for the cabinet, because MCOs have to be audited. We had to have reviews of their work as well, and for each one we have, it adds additional cost here. So I'm just trying to bring some common sense and semblance to this that's just not here. When I was elected in 2017, my interview with Renee Shaw, all new legislators get interviewed, and she started my interview with, I know you have 40 years healthcare experience. I guess you have a healthcare agenda. And I said it with all sincerity, no, I do not. It's a different world for me, and I've kind of purged all that gray matter from my brain, and I've got too many other interests I want to pursue. But if you follow my career here, you know that that has not been the case. And it's not that I'm a hospital advocate. It's not even that I'm a healthcare advocate, but I am a rural community advocate. And our rural communities are struggling like never before. You look at the last census, we've lost population on the east side of our state and the west side of the state. And the foundation for our economies in rural Kentucky are our school systems and usually our hospitals. It ripped my heart out 3 or 4 sessions ago when we gave $35 million to University of Louisville to buy a Jewish hospital. But at the very same time, Our Lady of Bellefonte Hospital in eastern Kentucky closed its doors at the very same time. And their issues were the same. The reason that Jewish failed was because of their payer mix, meaning that they had a disproportionate amount of Medicare and Medicaid patients they had to rely on compared to their competitors. Same issue with Our Lady of Bellefonte Hospital. We saved Jewish Hospital, did nothing for Our Lady of Bellefonte. Now, since then, it's repurposed itself and working at the University of Kentucky. I'm tickled to death for them, but that was a traumatic experience for that community. I'm saying Kentucky will not succeed if we allow any single community county to fail. And the foundation is, again, healthcare and education. And the challenge has never been like it has been before. This is just a small measure, but it speaks volumes. If we can reduce administrative burden, it'll provide some immediate relief to healthcare providers. It maybe let them live to fight for another day. But again, short of somebody giving me a convincing argument that we need 6, I just can't see it. So the essence of the bill, Mr. Chair, is that we only need 3. I'm asking for 3. That's the substance of the bill.
Thank you, Senator Meredith. What I'd like to do now is open up the committee for questions. Your first question will come from Senator Punky Perlmeyer.
Senator Meredith, I respect your tenacity. Did you say 7 years?
7 years, yes, ma'am. 7 sessions.
So when you say 6 to 3, I'm surprised I'm not hearing 1. But when it comes to determining, are we seeing better patient outcomes from one MCO over another? Is that something that perhaps we could expect or look forward to in the coming weeks with some testimony from MCOs to prove their patient outcomes versus the spend per capita?
Well, first, let me respond by saying the reason it's not 1 is the federal government. Center for Medicare and Medicaid Services requires a minimum of 2. And secondly, again, I don't like the MCO model. But I understand that the insurance companies, their fiduciary responsibility to their stockholders is to increase profits. I know that. And we do have the MCOs. They have testified at various committee meetings, most notably year before last. We had each MCO kind of present a State of the Nation kind of address. And they will speak glowingly about themselves and do a great job of pretty much patting themselves on the back. And I remember one of the issues we talked about is network adequacy, that we have rules that say that they have to have a certain percentage of primary care physicians and specialists and so forth. And they said unequivocally, we meet that standard. But we know in reality they do not. In a separate committee meeting, I asked Dr. Stack, our Commissioner of Public Health, and said, we had this testimony that network adequacy is sufficient for our Medicaid population. Is that true? He said, no, it is not. So we need to do a much better job of building in some accountability. But from my position, no, the health of our state has not improved in the 10 years we've been in managed care. Now, to their credit, I think we've gotten their attention a little bit on trying to address some of the social determinants of health that affect health care. So I commend them for that, but we're not anywhere where we need to be. But again, because their primary goal is to increase profits. And again, I'm not faulting them for that. That's what they're in business to do.
Is it all, Senator? Thank you very much. Senator Berg.
Thank you, Mr. Chairman, and thank you, sir, for this presentation. I'm going to begin with a comment, and then I do have a couple of questions. First of all, I think one of the biggest threats to medicine facing us at this point is something that's new on the scene, which is private equity companies coming in and buying out practices. And the reason, for those of you who aren't aware of what we're talking about here, the reason this is a real problem is that, again, you are talking about another chain of profits in the system that does not go towards actual healthcare delivery. So what you have is you have these companies coming in saying, okay, the doctors are overwhelmed. They can no longer fight the insurance companies to get paid for what they're doing. Their practice models are no longer able to sustain themselves. So what they're going to do They're going to sell their practice to a private equity firm who somehow is going to figure out how to make money for themselves in between this doctor-patient insurance company relationship. It's just a whole nother way of taking healthcare dollars out of healthcare delivery. And this is happening all over the country and rapidly. This is the new face of medicine. And we have got to do, as far as I'm concerned, everything we can to stop this. Stop it. Physicians need to be paid for their work, and they don't need to be fighting insurance companies day in and day out, tooth and nail, to get reimbursed for the work they're doing. So, that being said, sir, I agree with you wholeheartedly that the administrative burden placed on our healthcare providers at this point not only costs us dollars that should be sent to direct patient care, but they contribute to the lack of providers, to the burnout, to the fact that people are leaving this profession because it's just too frustrating anymore is actually the truth. So I have a couple of questions. If we go to a model with 3 MCOs, 3 questions. 1, do we know, is there a way to divide the risk pool evenly between them? Because that's one of the things I'm hearing from them, that some of them have different risk pools and therefore we can't compare one to the other, blah, blah, blah. So is there a way to at least attempt to do that? My second question, can we require combined credentialing so that if you get credentialed through one MCO, those same credentials are used for all 3 of them? You don't have to do a separate process. Should not be difficult. We have processes nationally where you can do this. I can't imagine. We can't come up with a process in the state where you can apply once. And then my third question is, can we somehow limit the audits? Because these audits are basically a way to waste time and money, particularly when you're getting audited by multiple different entities for the same exact things. I mean, it's almost like the prior auths. Once you prove you're good, I think you should be assumed to be good until you're found out not to be good. And all this, it takes time, it takes energy, it takes money, none of which goes towards patient care. So those are my questions, sir, and thank you.
I'll speak to the audits first. Most of those, if not all of them, are required by the Center for Medicaid Services. So I don't think that there's an opportunity, but obviously having to only do 3 compared to 6 reduces the burden there. I agree with your comment about what I call the corporatization of medicine. I think it's the biggest threat to healthcare that we possibly have. And I'm a capitalist to the nth degree, but no one should make a fortune off the misfortune of others, and that's what's happening. One of our MCOs last year, not off the Medicaid program, but their total book of business, their profits were $90 billion. I mean, $90 billion. And again, we have some of the worst healthcare outcomes in this nation. We can improve upon that. So we need to work on that. As far as what we can do is in terms of controlling, what I call controlling the MCOs, I think the Department of Medicaid Services and Commissioner Lee have done a pretty good job at that. But I think that always goes back to the RFP, how we develop that. And I think we can put in some tighter measures. We need to put in some tighter measures. We need some better measurable outcomes, such as network provider adequacy. So this gives an opportunity to do that. But again, they're struggling just like healthcare providers are. They're trying to ride herd over 6 different massive insurance companies, and they've got limited staff. So I think they would probably embrace this idea. Mm-hmm. And I think another thing that this does that you kind of alluded to is, particularly in rural communities where you have limited physician coverage to begin with, the standard is pretty much 15 minutes per patient. And doctors will tell you that they'll be on phone calls trying to get a pre-authorization for 15 minutes, and that's a patient you can't see. And another thing that complicates it even further, that even if you have a pre-authorization, and I heard this from the podiatry group this summer, that you get a pre-authorization, you provide the service, and then months later, the MCO comes in and says, we're going to deny this payment, and you need to send us all these records, and you can appeal it. So this is a game that we pay, but and I know we could talk ad nauseum about the issues related to billing, but it's a problem.
Thank you, Senator Meredith. Where are we at? Representative Chambers Armstrong, or I should say Senator Chambers Armstrong. My apologies.
No, thank you very much. And thank you, Chair Meredith, for your presentation. For someone who's still trying to learn more about this area, it was very informative, and I appreciate your passion for the rural communities that you represent. I am just curious, as someone who, again, doesn't have a lot of background in this, help me understand how we got to 6 now. It's not clear to me from the bill text in front of me. Is the law currently, does it say up to 6, or does the cabinet have discretion to award as many contracts as it feels are sort of viable from the applications it gets? Help me understand how we got to where we are and what we're specifically changing in the law.
Well, pretty much in 2012, when the program was started, it was done by executive order and done very quickly, and I think without a lot of forethought, because, as I mentioned, one of those 6, after they got into it, realized that they couldn't afford to be in it and exited the program and left a lot of people without coverage. So there's nothing magical about the 6 number. And if you look at various managed care programs across multiple states, you see numbers all over the place. Some as few as 2, but again, California, because of population 26, so there's nothing magical about the number. I think it goes back to the potential risk pool that's there, and I use California as a standard, 1.6 million population per capita. We're at 750,000, so that says we have room to run, and I think that's validated by Tennessee with their 3 MCOs.
That's very helpful. Thank you.
Thank you all very much for the questions. Do I hear a motion? Okay. Whose motion? Okay. Yeah. Thank you very much. Would you please call the roll?
Senator Rocky Adams. Senator Chambers Armstrong. Senator Berg.
I and explain my vote.
Go ahead.
I think, honestly, what we're doing here is really important, because we have got to figure out as a state what we can do to serve the most within our ability. And anything that we can do for our patients, for our constituents, for our providers, to make this process work better, I think we need to do it, because we are facing a crisis in healthcare delivery. We have shortages in essentially every medical field in the state at this point. We are desperately trying to keep the healthcare workers we have, and I really appreciate you, sir. I appreciate your commitment to healthcare delivery and to the actual patients. So thank you very much, and I vote yes.
Senator Carroll.
I'd like to vote aye and explain my vote, Mr. Chairman.
Go ahead.
Chairman Meredith, thank you for your continued efforts in this area. And for any of the new members, I'd love to have a conversation with you from the perspective of a lower level provider that provides therapy services and PPEC services for kids, and the struggles that we go through daily as an organization. A couple weeks ago, I saw where we had been trying to get paid $20,000, and we were at that year period. And staff came and said, we're going to have to write this off. My first thought was, they won this time, and that's their goal. And Mr. Chairman, it's I don't understand. We have providers come to us every year asking for increased reimbursement rates, when at the same time that we appropriate funds to increase their rates, we're also putting a heavier burden on them with the MCOs that cost them money. That's not a wise expenditure of state dollars to pay increased rates when really we can help our providers out simply by getting rid of 3 of these MCOs and lessening the administrative burden. There's no logic at all to what we're doing. There are no advantages to having 6 MCOs. The proof is here. Tennessee proves it. There's no logic behind it whatsoever. And why this bill does not move forward, for the life of me, I can't understand. You think about it, there's no reason for it not to move forward. So hopefully this year we can make some progress in it, but I'll be happy to speak with any of you about the struggles that providers face. Thank you, Mr. Chairman.
Senator Elkins,
Aye.
Senator Funky Fromeyer,
Aye.
Senator Meredith,
Aye.
Senator Nemes, Senator Tishner,
Aye.
Senator Wise,
I'd like to vote aye and explain my vote.
Go ahead, please.
Senator Meredith, I know you probably feel like it's Groundhog Day. 7 times, still here, but you're still fighting. You still have the passion. I appreciate your kind words about the work we have done with this committee and with your legislation. But it also is what the definition of insanity is. I'm sure many times we keep doing the same thing and getting the same results. This must change. I appreciate the work in the interim when you brought forth the Tennessee model that you showed and presented to us. I know we can do better in this delivery method, and I thank you as a colleague. I vote aye.
Vice Chair Douglas.
Aye. Senator Meredith, I'm happy to inform you that you batted 100 this morning. Some of us bat 1,000. I'm going to give you 100.
I understand.
Okay. Motion consent has been entered. Second.
Mr. Chairman.
With that being said, we need to have a voice vote. All in favor, please say aye.
Mr. Chair, if I could interject.
Yes.
I'm not sure that leadership's willing to entertain consent calendar at this point in time, and I would prefer that we just go through our normal channels to present this for a vote on the floor and discussion. Give folks that opportunity. So,
Thank you, Mr. Chair. I do appreciate that. But with that being said, the bill passes out of committee. I want to thank you so very much for your presentation and the information and the education that you've given us this morning.
Thanks, sir.
With that being
Appreciate
said, I would ask you to return to your position as chairman. And,
thank you. And thank you, committee.
We'll move on with the committee meeting.
Thank you. And our last order of business is consideration of referred administrative regulations. And as you folks know, we don't approve, disapprove these. We can find them deficient if that's an issue. I think there is some question on the second proposed regulations, which is 201 KAR 020.056, which deals with advanced practice registered nurse licensure certification requirements. And I see the folks coming to the table, rushing to the table. And thank you for being here this morning. If you would, please identify yourself for the record.
Kelly Jenkins, the Executive Director, Kentucky Board of Nursing.
Good morning, Jeff Prather, General Counsel, Board of Nursing.
Again, thank you both for being here. And Senator Douglas has a question.
Thank you very much.
Or comment. I'm not sure which. Or both.
Thank you very much, Mr. Chairman. I guess sort of my question is, how do we propose to go about establishing these particular certification requirements and ensuring that these requirements are met?
So basically, we're not doing away with the requirements. What we're doing away with is right now we are sending them a letter saying that your national certification is about to expire. So we give them kind of like a warning. Then we send them another notice, which we do not do that for any other licensure. So what we're doing is we're encouraging them to now participate with NurseSys, which is a national-wide database that they actually send a notification to them. And then also the certifying bodies, so whether they go through ANCC or who they're certified through, they also send them a warning letter, saying that they're about to expire. So we kind of just are trying to delete the redundancy and the work of the staff that it takes to send out these notices to remind people to get their certifications renewed. So we're still requiring them to be board certified. We're just not mailing a letter to say your certification is about to expire.
If I may, Mr. Chairman, one more
Yes,
question.
please.
I know there are required CMEs. Is that correct?
CEs, yes, we still require continuing education.
Where do they send? Do they simply obtain those, or do they obtain those and send them into a central data bank saying, yes, I have completed these?
So we do use a national firm. It's CE Audit, CE Broker. And we do that by audit only. So they're not required to send us the CEs. We randomly audit. And then if you're picked for the audit, then you're required to present, proof of your CEs during that time frame.
Okay. Thank you very much. Thank
You're
you,
welcome.
Mr. Chair.
Thank you. Are there any other questions? Senator Tishner.
Could you explain KAR 020220 regarding nursing continuing ed provider approval? Can you just expound on that a little bit, what that change is going to be?
So it's actually the application process itself. We went to a new software system, so it's completely electronic now. And so our material incorporated reference application actually had to be filed because we had to make some changes to it just for the software system.
Any other questions or comments? If not, there's a motion to accept the regulations. Excuse me, just this, we're acknowledging that we have reviewed the regulations and there's no deficiencies, so there's a motion to that effect. Motion by Senator Wise, seconded by Senator Douglas. All those in favor say aye. Aye. Any opposition by like sign. There being none, they move forward. And it is 9:57. Train's at the station. We stand adjourned. Please be reminded that our next meeting will be Wednesday, January 17th, 2024.